Good morning, everyone. I'm Ashutosh Kumar. I'm an assistant professor of pediatrics and neurology at Penn State College of Medicine. I'm also the associate medical director of Muscular Dystrophy Association Care Center and director of pediatric neuromuscular program at Penn State Health Children's Hospital. So I'll be talking about gene therapy offers hope for children with a rare neurometabolic disorder. These are my disclosures. I serve on the PTC Speaker Bureau program, and my involvement can be perceived as a potential conflict of interest, as I'll be talking about gene therapy, which is under development by PTC Therapeutics and not FDA approved. However, I'm going to present the available data and my own unbiased views, and I hope that you can make your own conclusions. So I'll start with a case presentation, then I'll describe the clinical features and diagnosis of aromatic L-amino acid decarboxylase or AADC deficiency. Then I'll talk about gene therapy for AADC deficiency. There will be some repetition for those who have attended my talk yesterday. So this is a case of an 8-year-old girl of Caucasian and Thai inheritance. She was born at 37 weeks of gestational age via C-section. Mother had history of fibroid. She stayed in hospital for 4 days due to temperature instability, some feeding issues, and neonatal jaundice. At around 4 months of age, parents were concerned about lack of head control and floppiness. Mother is from Thailand, so she went to Thailand with mom at around 4 months of age, where she stayed for 6 months. At around 5 months of age, she was diagnosed with urinary tract infection, for which she was seen by a pediatrician who was concerned about her development. So he made a referral to the neurologist. So she was seen by neurologist in Thailand at around 6 months of age. She was noted to have no head control. She was not turning over. She had reduced movement overall. She was disinterested in surroundings, and she was very hypotonic. She was also having these intermittent episodes of hypertonia and concern of seizure-like activity. At that point, her workup included a normal brain MRI. She had an EEG performed, which showed some sharp discharges in the left central region, for which she was started on Keppra. She had some basic genetic testing, including normal karyotyping and microarray. At around 8 months of age, a video EEG was performed, which captured 2 generalized seizures. Interictally, there was sharp discharges noted in the left frontocentral region more than right centroparietal region. Because of abnormal EEG and seizures, she was started on topiramate along with Keppra. During infancy, she continued to have feeding issues, increased startle reflex. She was increasingly sleepy, less active, not moving that much. She had increased sweating, intermittent high-grade fevers, and also noted to have global developmental delay. So family returned to United States at around 10 months of age. At that point, she had a repeat EEG, which was normal, also had brain MRI, which was normal as well, but she continued to have feeding difficulty, and slowly she stopped eating at around 1 year of age when a swallow study was performed, which she failed, and a G-tube was placed. She continued to have global developmental delay and severe hypertonia. Parents reported some episodes of head turning to the left and eyes getting stuck to the left side, which started a few months after she turned 1 year of age. She had a video EEG performed at around 18 months of age for 3 days, and these episodes were captured, which were thought to be oculogyric crisis, which initiated further workup. During this period, she had extensive workup, including basic CSF study, which were unremarkable. She had metabolic testing, leukodystrophy panel testing, and creatinine, along with some other tests. She had repeat EEG at around 2 months of age, along with MRI brain with and without contrast. She was suspected to have underlying neurotransmitter disorder, specifically because of this oculogyric crisis. And therefore, she underwent CSF metabolic profile testing, which showed low 5-hydroxyindole acetic acid, low homovanillic acid, and elevated 3-O-methyl dopa. And this pattern is consistent with AADC deficiency. So DDC gene sequencing was performed through MNG lab, which showed compound heterozygous mutation. This mutation is non-pathogenic founder mutation. She also had another variant which was not previously described, but it was thought to be probably damaging based on shift prediction model. A plasma AADC enzyme level was checked through MNG lab, which was below reference range, as well as she had low dopamine in the plasma. And at around 2 years, 4 months of age, she was diagnosed with AADC deficiency. So what is AADC deficiency? AADC deficiency is a rare inherited autosomal recessive disorder of neurotransmitter biosynthesis, which is due to pathogenic variant in DDC gene. And because of that, there is a dysfunctional AADC enzyme production. As you can see here that AADC enzyme is needed for the synthesis of dopamine as well as serotonin. So dopamine gets synthesized from L-dopa using AADC enzyme, whereas serotonin gets synthesized from 5-hydroxytryptophan. So if there is a deficiency of AADC enzyme, patient has low dopamine, low epinephrine or epinephrine, which is synthesized from dopamine, and low serotonin. And therefore, patients presents with symptoms of movement disorders, such as they have hypotonia. Typically, they have diffuse hypotonia, but some of the patients have axial hypotonia and appendicular hypertonia. They have dystonia, including oculogyric crisis, hypokinesia, bradykinesia, delayed motor development. Patients can also present with autonomic dysfunction, including ptosis, nasal congestion, hyperhidrosis, temperature issues, as well as gastrointestinal symptoms such as reflux issues, increased drooling, etc. Because of low serotonin, patients can present with behavioral issues such as irritability, excessive crying, or delayed cognitive and speech development. Since melatonin gets synthesized from serotonin, some of these patients can also present with sleep problems. So I'm going to show you the video of patients with AADC deficiency. This is a 2.5-year-old girl with AADC deficiency. She's having this oculogyric crisis episode. As you can see here that she has this right-sided upward gaze deviation. Which is consistent with oculogyric crisis. I can see here that she has low tone. She has this frog-leg posturing, and clinician is looking for the tone. She was reported to have diffuse hypotonia. She has reduced movement overall. As you can see here that she has poor head control, and clinician is supporting the head, and she is pulling to the sitting position. This is another patient with AADC deficiency. He is 31 months when this examination is performed. He was also noted to be severely hypotonic with reduced movement and poor head control. So these are the characteristic signs and symptoms of AADC deficiency. So this condition was first described in 1990 by Keith Hyland and Clayton. It is more common in Asian population because of the founder mutation. However, it has been documented worldwide. The mean age of symptom onset in these patients is around 2.7 months. However, the diagnosis may not be made until 3.5 years of age. So there was a delay of more than 3 years in symptom onset as well as diagnosis. It is predicted that United States birth prevalence of AADC deficiency is 1 out of 64,000 to 1 out of 90,000. And this is based on 2 studies. One study by Keith Hyland, they looked at metabolic profile of around 20,000 patients presented with non-specific neurological signs and symptoms and came up with birth prevalence of 1 out of 64,000. Another study performed by White et al., they had around 200,000 patients database, including their whole exome sequencing and whole genome sequencing, and they inquired those database for AADC deficiency and came up with birth prevalence of 1 out of 90,000. In other part of the world, in European Union, birth prevalence is estimated to be 1 out of 116,000. In Japan, 1 out of 162,000 because of founder mutation. In Taiwan, it has high prevalence of 1 out of 32,000. It is estimated that worldwide there are around 1,800 patients. However, only 150 patients has been reported so far. So more than 90% of the cases of AADC deficiency are still undiagnosed at this time. So how do you make a diagnosis of AADC deficiency? There was a consensus guideline recommendation in 2017 by Weisenberg et al. They recommended 3 core diagnostic testing for AADC deficiency. One is CSF neurotransmitter metabolite panel. As we discussed previously, that these patients have low 5-hydroxyindole acid, which is the metabolite of serotonin, low homovanillic acid, HBA metabolite of dopamine, and low MHPG, which is the metabolite of norepinephrine and norepinephrine. They have elevated 3-O-methyl-DOPA, but normal taurine level. And this is important to differentiate from some of the taurine disorders where they will have abnormal taurine level, but otherwise the profile might look similar. You can also do the gene testing either by a single gene or genetic panel testing to look for pathogenic variant in DOPA decarboxylase gene. Low levels of AADC enzyme can be also found in plasma enzyme assay. So it is recommended that typically patients should have 2 out of these 3 core diagnostic tests positive to confirm AADC deficiency. How do we manage the patients with AADC deficiency? Like many other chronic neurological disorders, management of AADC deficiency also require multidisciplinary approach, usually led by a pediatric neurologist, but team could also include a geneticist or genetic counselor, rehab physician with various therapists, an orthopedic surgeon if patient have spine or hip issues or contractures, dietitian due to feeding problems, and many others. There was a consensus guideline recommended different management options. However, most of this treatment either causes a temporary improvement in one or few symptoms, or most of the time not found to be helpful. The first line treatment includes dopamine agonists, MAO inhibitors, and pyridoxine. And these medications typically work by increasing the availability of neurotransmitters via different mechanisms. For example, dopamine agonists activate postsynaptic dopamine receptors and has shown to improve head control, hypotonia, ocular crisis, and autonomic symptoms in some patients. MAO inhibitors prevent breakdown of dopamine and serotonin, thereby increasing their availability. In some patients, it has shown to improve hypotonia. Pyridoxine or PLP, pyridoxal 5-phosphate, is a cofactor of AADC enzyme, and therefore that might increase residual activity of AADC enzyme. However, only one patient with mild symptoms so far has been reported to show a clear favorable response. Some additional symptomatic treatment could include anticholinergic agents, for example, trihexyphenidyl or benztropine, which likely works by influencing the relative imbalance between dopaminergic and cholinergic pathways. It has been used to treat autonomic symptoms, dystonias, including ocular crisis. There has been very limited evidence for use of benzodiazepines, in a patient, the slight improvement was reported in dystonia with use of clobazam. In another patient, rectal diazepam was effective in treatment of sustained oculogyric crisis. Melatonin, which is synthesized from serotonin, can also be deficient in these patients, and therefore has been tried in some patients with sleep disturbances with a variable response. Some other treatment options could include L-DOPA. Treatment with L-DOPA has been reported to be efficacious in patients with L-DOPA binding site variants. However, we have to be careful as this can worsen symptoms in other patients since they have already increased level of L-DOPA. Specifically, we should avoid combination of L-DOPA and carbidopa like Sinemet, as carbidopa is a AADC enzyme inhibitor and potentially dangerous in these patients. So folinic acid can also be tried in some patients, specifically if they developed secondary cerebral folate deficiency. It is important to recognize that there is no FDA approved curative treatment at this point. So what happened to the patient I followed? She was tried on multiple medications, including pyridoxine, bromocriptine, glycopyrrolate, Keppra, topiramate, and clonazepam for oculogyric crisis. There was no significant difference was noted after all this trial of medications. So family decided to travel to Taiwan and enrolled in a gene therapy, Eladocagene exuparvovec clinical trial. So Eladocagene is a recombinant adeno-associated virus serotype 2 vector containing the gene encoding the human AADC enzyme. And this is the construct for the Eladocagene exuparvovec gene. This gene replacement therapy delivers a functional copy of DDC gene in the brain where it is needed for synthesis of dopamine. So dose of gene therapy selected for use in patients with AADC deficiency was extrapolated from dose used in non-clinical and clinical studies in Parkinson's disease patients. So the low dose of adeno-associated gene therapy is delivered to both putamen by a stereotactic surgery. And as you can see in the diagram here, that putamen is a key structure where dopamine acts to excite the rest of the motor planning circuit, including globus pallidus, substantia nigra, thalamus, and prefrontal cortex. It specifically works through these medium spiny neurons and affect corticoputaminal loop. And that was the rationale to target putamen in these patients. So there were 26 patients studied in 3 clinical trials in Taiwan and 6 patients in Japan with the average follow-up of 50 months. The longest follow-up was available of 108 months, 9 years for one patient. So all the patients tolerated the procedure well, all showed improvement in oculogyric crisis symptoms, emotional stability, and motor function. As you can see here, that there was improvement on Peabody developmental motor scale, as well as on Alberta infant motor scale. The cognitive and language outcomes were also evaluated in this study using the Bailey-III cognitive Roy score and Bailey-III language score. And all the patients showed consistent improvement in cognitive and language scores as well. There was also an objective evidence of efficacy of gene therapy. So CSF homovanillic acid, a metabolite of dopamine, significantly increased 12 months after gene therapy, whereas there was no significant difference in CSF 5-hydroxyindoletic acid, 5-HIA, the serotonin metabolite level after gene therapy. Because serotonergic nuclei were not targeted in this procedure, and therefore it was thought that a CSF HIA level did not significantly differ. As you can see here in the picture, that PET showed increased putaminal uptake of F-DOPA at 6 months, and 5 years after gene therapy. And this likely indicates durability of one-time gene therapy. Patient also showed improvement in weight gain as well as pulmonary function. Typically, these patients have weight gain issues, specifically after 1 year of age. Most of these patients require G-tube. As you can see here, that baseline, most of these patients have weight percentile less than third percentile. However, after gene therapy, some of these patients were able to go into more than 25th to 50th percentile of body weight, and some even went up to 75th percentile. You can see also on the right side that episodes of respiratory infections and pneumonia also reduced over time in all these patients. The most commonly reported treatment emergent adverse events across all three studies were pyrexia in 96% of the patients, and dyskinesia was noted in 92% of these patients. Dyskinesia is thought to be a marker for dopamine production and likely resulted from dopamine receptor hypersensitivity. But all of these dyskinesia events resolved within 10 months of treatment. Some of the other adverse events included URI symptoms in 69% of the patients, gastroenteritis, pneumonia, upper GI hemorrhage, and diarrhea. But most of these adverse events were very mild or moderate in intensity. 11 patients had severe adverse events requiring hospitalization. CSF leak was noted in 3 patients, and that was considered to be related to the surgical procedure itself and not to the gene therapy, and that resolved without any consequences. There was no viral shedding in any patients through 12 months after gene therapy. There were 2 deaths reported in this study. One patient died because of influenza B encephalitis at 11 months after treatment. Other patients died likely due to aspiration 5 years after gene therapy, but none of these deaths were related to the gene therapy. I'm going to show you the video of patients who received gene therapy, the initial evaluation of, as well as after treatment with gene therapy. So baseline examination was performed at 13 months. And as you can see, that patient had poor head control. He was very hypotonic. 1 year after gene therapy, he is able to get up from the laying position and crawling. He can stand with some support. This is the 2 year after gene therapy. He's able to pull himself up. And can take few steps holding hand of the clinician. And this is a video of 5 years after gene therapy. As you can see here that he's able to pull himself up. He's able to walk independently. And you can see here that he's been running probably faster than the clinician. He's able to traverse the stairs holding the railing. And this is not expected from the natural history of this study. So I'm going to show you the video of another patient with ADC deficiency who received gene therapy. And this is the same patient we talked initially. This is the initial evaluation at 31 months of age, where you can see the poor head control, hypertonia, reduced movements. Nine months after gene therapy, he's able to lift his head up. He's interacting with clinician, reaching for things in the midline. Now you can see he has better head control now. And he was showing cognitive improvement as well. So definitely there is a significant improvement before gene therapy and after gene therapy, which again is not expected from natural history of the disease itself. So investigator at UCSF and Ohio State University, they took another approach and infused gene therapy to midbrain, specifically substantia nigra and ventral tegmental area, VTA, which are important structure in nigrostriatal pathway. So bright signal depicted by white arrow in picture A shows coronal, and picture C shows axial MR images confirming vector infusion into substantia nigra and ventral tegmental area regions. Picture D shows baseline DAT scan of the striatum confirming a normal pattern of dopaminergic innervation, and that is indicative of preserved nigrostriatal pathway. Picture E and F showed baseline F-DOPA imaging of the midbrain and the striatum. You can note the lack of signal in both regions, indicating impaired conversion of F-DOPA to F-dopamine due to AADC deficiency. Whereas picture G and H showed increased F-DOPA PET uptake 3 months after gene therapy infusion in the midbrain and the striatum, respectively, as you can see here. There was also changes noted in the oculogyri crisis and motor function after gene therapy. As you can see here that by 3 months post-gene therapy, OGC completely resolved in 6 out of 7 patients studied. One patient has a residual OGC throughout 24 months study duration, but severity decreased after infusion. So baseline gross motor function measure 88 score were less than 10 for all subjects, and that is consistent with severe motor impairment. A clinically meaningful positive change, more than 7 points, were considered as significant, and that was seen in 6 out of 7 patients by month 12. So there was a significant improvement in both these parameters as well. Like previous study, this study also looked at CSF homovanillic acid and 5-hydroxyindolestic acid level. So homovanillic acid, which is a dopamine metabolite, was significantly higher at each postoperative time point, 3 months, 6 months, and 12 months compared to the baseline mean. But 5-hydroxyindolestic acid, which is the serotonin metabolite, did not change after gene delivery. There was a persistent elevation of 3-O-methyl-DOPA after gene therapy, and that was consistent with degree of residual AADC deficiency. All 7 patients tolerated the procedure well. At around 3 to 4 weeks, all subjects developed dyskinesia, which improved over subsequent months. There were 10 serious adverse events reported in this study. One patient had hypoglycemia following sedation for a study procedure, and that was thought to be related to AADC deficiency. There were non-specific symptoms such as 5 cases of viral URIs, 1 hematomesis with GERD, and two reports of pneumonia, one UTI were reported. There was one fatality 7 months after gene therapy, which was attributed to primary disease itself. It is difficult to do a comparison between these two studies since they are different targets. They used different functional motor skills. In the second study, there was only 7 patients, whereas the previous study has around 26 patients. And Pearson study was also an early phase of clinical trial with safety as the primary objective in that study. So it is hard to make comparison because there's no head-to-head comparison that which one, is it better to infuse the vitamin or better to infuse the midbrain at this point. So my patient, she received gene therapy at 2 years and 11 months. She developed severe dyskinesias for 3 months, which completely improved over time. After 1 month of gene therapy, she started lifting her head up. She was becoming more interactive and making developmental progress. At around 5 years of age, she was able to finger feed herself, chew food. G2 was only used for supplementation. She had full head control. She was sitting without support, bearing weight with support, and was able to crawl. She was more vocal, but some of the words were incomprehensible. She was noted to be more interactive, socializes, making some cognitive improvement. She also noted to have improved temperature control because that was an issue in her prior to that. At around 6 years of age, she could walk with some support. She was speaking few words and made cognitive improvement to the point that she started going to the school. As family moved to the different areas, they could not follow her after that. So in conclusion, AADC deficiency is a debilitating neurotransmitter disorder, which is often undiagnosed or misdiagnosed in most of the patients. AADC deficiency should be considered if a patient has key signs and symptoms of hypotonia, motor developmental delay, dystonia, including the oculogyric crisis and diurnal fluctuation of symptoms. And gene therapy appears to be safe and may dramatically change the disease trajectory. That ends my talk, and I'm happy to take any question.